PA SI joints?
We shoot the entire pelvis, yeah. In the book, this view as an AP or the optional PA, they do collimate it just to the SI joints, but our protocol here at the hospital, similar to like when we do fingers, and we do the PA a whole hand, and they collimate it for the fingers, we're going to do the same thing here. We'll try to get the whole pelvis all on one, so we'll shoot it on a 14 by 17. And then when we're doing the oblique SI joints, we can use an 8 by 10 or a 10 by 12 and just get the side of interest. But for this first projection, most of our techs will do a PA with no angle. You absolutely can throw an angle in there. It will make those joints appear more open. Okay? If you're choosing to do an angle, it's a 30 to 35, and with the prone position, it will be a caudad angle. So it will look like this. With collimation to the pelvis. Now, when we shoot a normal straight ray pelvis, where do we center?
From the ASIS
Midway between the ASIS and the symphysis. Yeah, so it says mid-pelvis. We have an angle. How do we alter our central ray location? In the opposite direction of the angle. So we're angling down, therefore we will move our tube in a north or superior direction. And again, you can kind of judge off of where your angle, open your collimator up, see where your line is going, approximate midway. You want it to enter between the ASIS and the symphysis. So if your collimator up, see where it's entering, it'll seem higher. Okay? You will be more superior than a normal pelvis. So we expect that on these. So it will look something like that. Okay? If you're not sure and you have to keep one way too high, maybe you put the hair off the ischium and the rami, that's fine. We're not super concerned about that, but we do try to get the whole pelvis all in one. So that is our first image. Now, if they come to the department like this, we will shoot their obliques like this as well. Okay? If we were to shoot her obliques, anterior oblique, which side would we be demonstrating?
downside.
Side down. Her joint's set like this, so when we roll her one way or the other, we're looking at the downside joint. Okay? They sit open to the front. If she can roll over, a lot of us roll her over, it puts the joints generally less OID. So go ahead and roll over. We'll demonstrate shooting you in a supine position. Okay, we have our little tiny cassette here. Mark the downside. Some people on these, because the upside is the side of interest, they'll mark the upside. That is okay on these ones. But if you have it in your head that we mark the downside, go ahead and mark that downside.
So you want us to mark the downside when we roll?
Well, that's our general rule. But if you think that's going to collimate off, because we're looking at the upside in this position, you can throw a left marker on there to view, say that we're seeing the left side. Okay, sponge. 45-degree sponge. What do you think? Yep. Okay, actually, let's go the other way. I'm going to show you the other way. There you go. Okay. The way we're going to use it as a 30 instead of a 45 is we're not going to put it all the way back behind her. Wow. Next, we will x-ray down thoracic side. Okay. What is our positioning rule here? What are we looking for? What's our landmark?
The dimple on the back.
The dimple on the back, the little hole on her. Upside ASIS. Remember the picture that we looked at when we roll her up like that? That SI joint is right off of that crest and that ASIS. Just an inch in from that ASIS will put you right on. It's a fairly easy positioning actually. So we find our upside ASIS right there. And that is where we are.